Okay, great. Thank you. I want to welcome everybody to the IFAM series that we hold every Thursday of the academic year. Today, our featured seminar is on the opioid crisis that's been eclipsed by the SARS-CoV-2 pandemic. So many academics and the CDC are pointing to actually a fourth wave marked by a significant acceleration of more than 30% between 2019 and 2020 of opioid overdose deaths. And some states were recording a record 70% increase in opioid overdose deaths just at the first year of the pandemic. The data are not finalized for the year 2021, but we hear from individual states they're also seeing record accelerations again. I'm going to introduce our speaker here in a minute, but I wanted to remind the audience that please use the Q&A for questions and don't use the comments, and therefore I can know where to look and find them, and we'll go through those at the end of the talk. So having said that, it is my very great pleasure to introduce Dr. Mason, who is a colleague and a researcher in the Department of Emergency Medicine. She is also the Associate Director of the Buehler Center for Health Policy and Economics. And Dr. Mason serves as the Principal Investigator for the Illinois Violent Death Reporting System and the Illinois State Unintentional Drug Overdose Reporting System. This is a national effort by the CDC. Dr. Mason's work focuses on injury control and the prevention of homicide, suicide, and drug overdose deaths. And with that, I'm going to turn it over to Dr. Mason. So go ahead, Maryann.
Thanks, Lori. And hello, everyone, and thank you for attending today. I'm really pleased with the turnout, and I hope we all learn something together today. So Lori introduced me. I don't need to provide any more background, I think. Let's see. Of course, I have to figure out there we go. And just want to start off by disclosing that I have no conflicts of interest to report. I always like to start my talks on this topic by acknowledging the loss of life to overdose, and keeping in mind that the numbers we're talking about are people that family and friends lost to opioid overdose. And so that we keep that at the center of our work to keep it meaningful and remind us of the importance of the work. I also like to acknowledge my colleagues and peers in this work, particularly Drs. Post and Kim, who were co-authors on this publication, and Dr. Lundberg, who is in the Buehler Center for his statistical support on the project. And also a student intern, we had Rebecca Solomon, who contributed to the work I'm presenting today. The work was funded by an anonymous donor. And I also want to acknowledge and share gratitude for our team of data abstractors who collect data on overdose deaths and help us prevent these deaths in the future. We couldn't do this work without their contribution. So thanks to everyone who helped make this happen. I have a couple of very simple goals today. One is just preventing the research on opioid overdose death among older adults to help people understand what's going on there, particularly in the context of the current opioid epidemic. And then help us think through what some of the implications are for given those findings for how we prevent older adult opioid overdose death. So I hope that this presentation will take us further down the road on each of those areas. I also want to share kind of a very basic statement of work for this talk. So our first thing of importance that comes out of this work is we're looking at opioid overdose as a growing cause of death for older adults. And this group has been largely overlooked when we think and talk about the opioid epidemic. So we feel that this work is important just by calling attention to the older adult. Then secondly, this work looks at some deep racial and ethnic and gender disparities among older adults who die by opioid overdose. And so that is kind of a new contribution to the discussion here and something we're able to provide. And then lastly, as I said before, we want to use these findings to inform our prevention approaches. So let's get right into it and talk about opioids as a public health problem. I like to think of opioids as an iceberg problem, meaning parts of the problem are above the water and very visible. So in this case, we're looking at opioid overdose deaths. That's the most obvious loss associated with the opioid epidemic in the United States. And in 2020, we lost 69,000 people to opioids. But there's a much larger part of the problem kind of under the surface, and that is non-fatal overdoses. There are between 6.4 and 8.4 non-fatal opioid overdoses for every fatal overdose. And non-fatal opioid overdoses have very significant physical health consequences. They can actually contribute to brain damage and other physical health problems that are very, very hard to bounce back from. So it's a significant contributor to illness and loss of functionality. But even beyond that, the misuse of opioids is very pervasive in the United States. In 2020, it was estimated that almost 9.5 million people aged 12 and over misused opioids in the last year. So the scope of this problem is just enormous. And that's one reason we've taken focus on it. So opioid use, what could go wrong? Opioids are very powerful and very dangerous. Some of them occur naturally, like heroin. Some of them are semi-synthetic, so things like oxycodone, and some are fully synthetic, like fentanyl, a very powerful opioid. But in general, opioids are very powerful, and they have a lot of consequences to them. The first would be developing a tolerance. So that just means that as you use an opioid, your body requires more of the opioid to get the same effect. And then the next step would be dependence, which is that you have unpleasant symptoms when you try to stop taking the opioid. And then the full blown I guess, escalation of this would be opioid use disorder, when you're failing in efforts to cut down or stop, and it's interfering with your functionality, with your family, your school, your home. So opioids can be a problem. Opioid use disorder is kind of a new way of talking about the idea of addiction, which we don't like to use because it has a lot of stigma to it. But opioid use disorder is not the only way people are harmed by opioids. It's such a powerful substance that people who taking an opioid for the very first time can have very negative effects. And then in terms of overdose, basically your body is injured when you take opioids in excessive amounts. But then death, you can die from opioid overdose. It's basically a form of poisoning, and you're just ingesting an excessive amount of opioids. So I want to give you a trigger warning for this next slide. There's some pictures that are kind of shocking. This next slide is about opioid overdose death. And the mechanism by which opioid overdose death occurs is that respiration is depressed following taking an opioid. And basically your neurotransmitters that control your respiration are inhibited. And an overdose death can happen at any point in your use of an opioid. It could happen the first time a person uses an opioid, or it could happen after years of an opioid use disorder. That's how dangerous opioids are. So this first picture to the right shows one of the telltale signs of an opioid overdose, which is the foam coming out of the mouth and nostrils. If you're doing a death scene investigation for a suspected drug overdose and you see that, you're almost certain to find an opioid overdose. And then this picture down below is evidence of a rapid opioid overdose. So if you look closely, you can see that this woman has a syringe in her right hand, and she collapsed immediately after injecting and fell forward in this way, which is a classic sign of a rapid opioid overdose, kneeling forward. And so rapid opioid overdoses are a particular kind of overdose where rescue is limited, but it's particularly tragic because we know no amount of intervention could have helped. Okay, so things that affect your opioid sensitivity are your genetic makeup, your metabolic function, how well your body processes things, whether or not you're using other substances or substances that are contraindicated, and your tolerance. If you've built up an opioid tolerance, you can take more, obviously, without a negative impact. So a lot of people ask me, why am I interested in the older adult opioid overdose death? And this actually came about very organically. A large part of my work is community partnered work. And I will say throughout my career, most of the most interesting questions I've looked at as a researcher are questions that have come up in community contexts. And this one is no different. In 2019, I was working with the Illinois Opioid Overdose Education and Naloxone Distribution Program. And they asked me, could I take a look at what was going on with older adults in Cook County, because they thought they were seeing a bump up in opioid overdose death. And then at the same time, I am a member of the Data Solutions to Opioid Overdose Crisis Committee in Cook County, and the members there were also talking about what they were seeing with older adults. So I was curious and responded to a community request. So I ran some simple statistics with our SUDORS data, which are the public health data, surveillance data on drug overdose death in Illinois. And I saw these orange squares popped out at me. There looked like to be a very big disparity in terms of the age groups impacted by opioid overdose and as they clustered along race groups. So basically we find that non-Hispanic Black people in Cook County had much higher rates of opioid overdose in the older age groups, so 45 on. Well, that got me interested, and I started thinking, looking at the literature and about the older adult and opioid overdose, trying to educate myself on that. And mostly what I found was literature having to do with prescription drug use in the older adult and how the interaction between opioids as prescribed for medical needs and the process of aging created risk for older adults in terms of opioid overdose. So I started thinking about, what are the sort of collections of physical health problems, and how are they interacting with medically prescribed opioids, and started thinking things through. And then I decided to look at some of our data. We collect narrative data on each of these deaths in Cook County. And here's just some examples of narratives we've had on older adults. So this is a 71-year-old Black male who died from a combination of fentanyl and heroin, cocaine, and alcohol. There was drug paraphernalia found, including a spoon in Ziploc bags. This person had a medical history, particularly a history of heroin use and hypertension, diabetes, and maybe osteoporosis. So this wasn't what I was expecting, but then I thought, oh, maybe this is an anomaly. So I continued to look, and here's just another example. A 63-year-old Black male had a history of drug abuse. He had no prescription medications. He had some sort of heart condition and is known to use drugs, but he was not taking any medications, and he died from an overdose of heroin and fentanyl. So I'm thinking, where are all the prescription drugs in combination here? So here's my last case I'm just going to show you. This is a 60-year-old white woman who there was illicit drug paraphernalia found around her. She had a history of chronic heroin use via snorting for chronic back pain and some psychiatric disorders. And then this is her toxicology. And she was positive for antidepressants, benzos, THC, fentanyl, a lot of drugs, but oddly no heroin. So the upshot of this is it was not at all what I was expecting. I really was expecting to see how prescribed opioids were interacting with the older adult. But what I really was finding was that there was a lot of use of non-regulated substances by older adults. And so I looked into this a little bit more, and this is a unique older generation in that they are the baby boomer generation, which is different than generations of older adults that have gone before because they've maintained their substance use at higher rates than previous generations. So the baby boomers, this current generation of older adults, are substance users at much higher rates than prior generations. So this makes them somewhat unique as we think about how to understand the connection between opioid overdose death and the older adult. So that began a research agenda for myself and our team, looking at the older adult and opioid overdose death, looking at it in terms of the narrative of the current opioid epidemic. And in particular, I wanted to know was what I was seeing in Cook County part of a national picture, or was it unique to Cook County? And then especially those race and ethnic disparities, are those happening nationally, or is it just Cook County? So we had some goals, and we set about doing some work on this. So I want to take you into the older adult population, what makes them a little different right now, and why they're a population of interest for looking at substance use. One thing is that we are getting older as a society. So the share of the US population that is an older adult is growing. We're also becoming more racially and ethnically diverse in terms of our older adult population. This population is working longer, staying in the workforce longer than previous generations. It's more economically diverse. The traditional gap between women's life expectancy and men's life expectancy is actually narrowing. And people are living longer with health problems. It used to be people would die in their 50s and 60s of things like cardiovascular disease, but our healthcare has advanced so much that people are living longer with those health conditions. So it, in some ways, could be a sicker population. But what else is kind of unique about this generation is it's a very, tough it out. I survived. Nothing wrong with the way we did things. I'm fine now, which can make it a little difficult for this generation to seek and find help for problems they're having. So I'm going to take you into some of the details of our study. So this is the first in what we think of as a series of studies on the older adult. And this came out in JAMA Open in January of this year. And we looked at disparities by sex, race, and ethnicity in the opioid overdose death rates among adults 55 and older. We looked at the time period 1999 to 2019. So we're using multiple cause of death data that come from the CDC Wonder system. And those death data are really from death certificates. There's one underlying cause of death listed on a death certificate, and then up to 20 different multiple cause of death listed. So we looked at the multiple cause of death to make sure we're getting the full picture. And we are comparing death rates between those less than 55 and those 55 and older. And then just within the 55 and older age group, looking at the race, ethnicity, and sex subgroups in terms of their opioid overdose death rates. And we included cases if the death occurred between January 1, 1999 and December 31st, 2019. And then later we expanded some of the analysis to 2020 as those data came out. And to be a death in the study, you had to have a death manner coded as unintentional, suicide, homicide, or undetermined. And you had to have a substance listed as contributing to the death, including one of these, one or more: opium, heroin, methadone, other synthetic opioids, so that would be like a fentanyl, or other unspecified narcotics. So that gives us a complete picture of the opioid overdose deaths. And this is a standard definition used by the CDC and many, many others. And so then our analyses, we looked at some line graphs, comparing groups, and we did a multivariate regression parameter estimate to really look at the trends of the lines. And I'll show you those. So the first question we came up with is, how do the older adults' opioid overdose death rates compare to the younger adults? And again, the age groups are less than 55 and 55 and older. Okay. So this is a pretty simple graph to interpret. The top line would be those less than 55, and the bottom later line is those 55 and older. What you'll note is, while the rates are lower for those 55 and older, they follow the same general pattern of increase of those 54 and younger. So if we tell the story of the opioid epidemic in the United States, the older adults are following right along. They're in it, they're part of this. Okay, so between 1999 and 2020, opioid overdose death rates for those less than 55 increased 7-fold. But for those 55 and older, they increased 15-fold. So rates are increasing more quickly for the older adult. So even though they're following the general pattern, they do seem to be accelerating at a pretty good clip. Okay, so then I want to, pardon me, want to get to our second question, which is really about race, ethnic, and sex group disparities among opioid overdose rates among the 55 and older crowd. So as you'll recall in one of the first slides, I noted that African-American opioid overdose deaths in Cook County trended older than for whites and Hispanics. So I kind of wondered, was this the case nationally? And please excuse my my drawing on here, but I want to make some points with this. So what we did was graph the rates for each of these groups. They're male and female versions of 4 different racial groups. So they're Asian, Pacific Islanders, non-Hispanic Black, non-Hispanic White, and Native Indian and Alaskan Native. Those are the 4 race and ethnic groups. Then we had Hispanic and non-Hispanic for the ethnic groups, and then male and female. So the first thing you see when you look at this line graph is this group that shoots off on its own to very high rates, and that is non-Hispanic Black males. So non-Hispanic Black males that are 55 and older are bearing a disproportionate burden of these deaths. I think the second thing you'll notice, and I circled it here or tried to, is that there are both male and female, Asian and Pacific Islander older adults don't follow the larger opioid epidemic story of increasing rates. They maintain very, very low rates toward the bottom. It's almost like they're protected from the opioid epidemic compared to their peers of other race and ethnicities. So those were the 2 big things that stuck out. Now this is our parameter estimate. So we're looking at the intercept here. And when we do that and compare them, we can identify 3 significantly different trajectories among these groups. The first one is the Asian, male and female Asian, and also we can group the female Hispanic, Latina group in there. Those have the lowest rates, and they generally don't have much of an increase over time. And then there's this middle ground, which includes female, non-Hispanic Black, female non-Hispanic White, female non-Hispanic American Indian, male Hispanic, male non-Hispanic White, and male non-Hispanic American Indian. And they have followed a moderate increase. So over time, they're following the larger epidemic, but at much more moderate rates. And then the red line here, again, are the male non-Hispanic Black men who are on a trajectory of their own. Their intercept is twice that of the next highest group. So twice that of the American Indian males. So again, since 2013, so this takeoff on its own trajectory for non-Hispanic Black males began in 2013, and then in 2015 it accelerated much, much more rapidly, almost a straight line up. And as I mentioned earlier, the Asian male and female seem to be almost unaffected by the epidemic. And then this middle group, they experienced an increase in these deaths over time, but it was nowhere near that of Black men. So following the general epidemic, but at a moderated rate. Okay. So sex disparities are pretty much significant for groups other than the Asian group. The Asian group are both low for men and women, but in terms of the other race and ethnic groups, males are always higher. And the disparities between the American Indian male and females are the lowest, and the disparities between the non-Hispanic male and female Black groups are the highest. So these subpopulations are definitely having different epidemic experiences. I tried to put together something that told the story, looking at this, comparing it to what was going on with the under 55 crowd to illustrate this. I'm not sure how well it came out, but basically the under 55 crowd has a different racial ethnic pattern going on. Again, the 55 and up crowd is on top of the line here. You can see they're disproportionately affected beginning in 2013, and they go all the way to 2020. whereas there's some different patterning going on in the under 55 crowd. In the under 55 crowd, whites, non-Hispanic whites are disproportionately affected. They're the most affected group from 2014 to 2019. And then it switches up in 2020, and American Indians have the highest rate, followed by non-Hispanic Blacks. So you can see that, again, the age groups are having different epidemics in terms of their opioid overdose rates. Okay, so I'm going to take a few minutes, see how I'm doing in time here, and just talk about some of the implications of this and how we might need to change our thinking about the older adult. One thing that goes on with older adults is it can be very easy to mistake substance use for other health issues or aging-related cognitive decline. So it can be tricky, can be trickier to recognize this. But there's also something going on in our perception of the older adult, which is we may perceive them with ageism, which would tell us that this isn't a population that uses substances, so we don't have to worry about them. They don't have to be screened. But clearly not the case, and we need to question our approach to ageism. I include these pictures here below because each of these people is recovering from substance misuse, and it's not what we generally think of when we think about people who are in recovery from substance misuse. But I think we need to challenge ourselves to break out of that ageist mindset. The other tricky thing about the older adult is their opioid use risk may be different than for younger adults. Not all the risk could be related to being dependent or misusing drugs. There are, excuse me, physical health complications that put older adults at higher risk of negative outcomes from opioid use. Things like polypharmacy, taking multiple medications, health conditions, cognitive decline, and then having an exaggerated effect when you combine substances. Those impacts can be more severe for the older adult. The other issue about opioid risk in the older adult that may be different is, especially for older adults who've used opioids for long periods of time, like some of the people I shared the narratives with you of, is that things may happen over time that put people at higher risk. For example, the way bodies change, the way bodies metabolize substances could change and make them more sensitive to them over time, but they may not be cognitively aware of that. You could be using, relatively little, but it can impact the quality of your life at a lower amount than when you were younger. And I think we've seen a fair amount of this where people have had a long-term heroin use issue and they've used safely for a long period of time, but then there's a change in the drug markets, and so that their old habits have new risks. And that may be especially true for older adults. And then I think we have to consider the possible contribution of a contaminated drug supply and how that might impact the older adult who may be at risk. And I'll just say this about that is often the opioid epidemic data starts with the year 1999 and shows how things have grown. But it's not true that there were no problems before that. In the 1970s, there is a heroin epidemic in major cities. In the 1980s, there's a major crack epidemic in the United States. So you may have people who've lived through those epidemics and have managed to continue using, but safely, who now may be at risk because of the contamination of the drug supply, particularly as fentanyl becomes more and more frequently detected in the illicit drug supply. So all of this says that I think we need to screen older adults for opioid use and substance use in general more than we are now. So the recommendations are that screenings are done yearly and at major life changes. And as older adults' lives develop, many major life changes can occur. The death of a spouse, retirement, moving, all those sorts of things are major life changes that happen later in life. And substance use can change along with those major life changes. The screening may have to look a little different for the older adult. You may need questions about over-the-counter drug use, alcohol. Alcohol is the most frequently misused substance for the older adult. So certainly asking about alcohol is important. And other non-regulated substance. And again, I think we've seen this in our data where people might be using cocaine and have used it safely for a long period of time, but now the cocaine supply is contaminated with fentanyl and they have new risks. They have an opioid risk on top of other risks. So we need to be asking about ways people could come into contact with opioids that aren't necessarily top of mind. And then there are many, many settings where screenings could be done in home settings, in care settings, in social settings. Those all need to be thought of as potential touch points. So let's think about substance use treatment in the older adults. So there has been an increase in older adults seeking admission to treatment starting in 2012, which is a good sign. But we have to keep in mind that while opioid use disorder is certainly a threat to many in this population, we may need to incorporate treatment for other substances in addition to opioids, in particular alcohol. And then we have to think about medication-assisted treatment for opioid use disorder and how that works with the older adult. The use of medication-assisted treatment is growing with older adults, but it's still less often offered and less often, excuse me, implemented compared to younger adults. So I think we have some room to grow there. Excuse me. Medication-assisted treatment has some special considerations for the older adult. In particular, methadone may be problematic, may need to move away from that due to comorbid conditions. But buprenorphine may be a preferable choice there, so have to balance those needs out. The other issues with treatment is treatment can be different for the older adult. They may actually benefit from a less intensive approach than younger adults. There is growing acceptability of seeking treatment among older adults, so that's good news. The other good news is there's evidence that older adults can be more successful in treatment than younger adults. There's been studies looking at social emotional intelligence and wisdom and how that can impact treatment success, which is unique to the older adult. But we also have to think about how we can adapt current treatment models for the older adult in order to reach them and ensure their success. So things like different modalities for hearing and vision impaired persons, just even where treatment is located, can people get there? Things like that. Okay. And also, if we look at the data and we see that older Black men are disproportionately dying from opioid overdoses, then we may need to think about tailoring some outreach approaches to the older adult Black male population. And here's something like the trusted messenger outreach model, which is used in a lot of different health conditions. This picture I have on the screen here is actually for asthma, but it's been used in many, many health conditions. But can we adapt that model to the substance use world for the older adults? And in particular, focus on harm reduction, especially for those who have long-standing substance use issues. Can we help people with long-standing issues use their substances more safely? I think those are two big concerns. I think there's also a lot of opportunity for research and expanding people's access to treatment that go along with the Medicaid expansion that just happened very recently. So the near elderly, the 54 to 64-year-olds, have increased coverage, and getting them into treatment may be easier because of that. Then I think we also have a big question about telemedicine. How would it work for older adults? It has some potential benefits in terms of, easing access and addressing mobility issues, but we're just not sure how well it works in terms of the technological interface and things like that. So that's sort of the implications portion of the project. I just want to leave you with a little description of what we have going on now in our center around substance use. We have some interesting projects. One is we're going to start a small area naloxone distribution pilot project in 3 sites in Illinois. We'll be starting that this spring and summer. We currently have a qualitative interview project focused on the older adult and those who provide care to the older adult to better understand opioid use in this population. And again, to see if we can identify touch points and strategies for outreach and prevention. We do have a project we're trying to work on where we're trying to look at what are the most common combinations of physical health conditions among older adults who are dying by opioid overdose. Pardon me. And one of the things I'm most excited about is we have a community engaged research partnership with the Northern Illinois Recovery Organization. And this partnership, it's funded by an ARC seed grant, but it's really trying to look at what's the intersection for people of color in recovery from substance misuse and issues that come up with managing chronic health conditions. And so we have 3 or 4 different things we want to work on in that area. And if you go to this link, you can see them. We have a partnership with Yale and George Washington Centers for Health Informatics to bring big data approaches to the SUDOR's data that we're hoping to implement in the near future. And then we are planning an NIH grant to do some big data analysis where we can profile the cluster of conditions that older adults who die by opioid overdose have in common in order to lead us to some prevention approaches. So we have a bunch of sort of questions under that. Lots of different issues around what's going on with toxicology, what's going on with their history of substance misuse, all sorts of things. So we hope to submit that this spring, more likely this summer. And I always want to include information about how people who are struggling with substances can reach out and get help. So Illinois has a central hotline or helpline for people who have want help with substance use, and it's here. And then also if you want to become a helper, if you're concerned about opioids and how you can be a helper, there is a way you can register to become to be trained and administer naloxone, which is a opioid overdose reversal agent. So want to leave that with people today. And then finally, a shameless plug for the Buehler Center. If you join the Buehler Center, you can get updates on this work and all of the work in our injury control portfolio. And also we have an event coming April 22nd where it's called Ask an Economist, and it just allows people to bring questions they have where they want kind of the perspective of a research economist on it to discuss how they might approach a research topic. And it's usually a fun and interesting event. So with that, I guess I'll turn it over to Lori.
Thank you. And so just to remind everybody, please use their question and answer because I can't read the chat room in this mode here. The first question is, Maryann, is there a difference in intentional and unintentional death rates in older adults during the study period? Basically, suicide versus unintentional.
So that is not a comparison we made. We didn't break it down by intentionality, but certainly would be something to do going forward. We have done work on the role of opioids in non-poisoning suicide deaths. We've published on that in the past. It has not gone up as much as one would have thought it would during the opioid epidemic, but great question. I hope to look into that in the future.
Thank you. Another question I have is, what do we know about the distribution of naloxone by age, or do we know anything?
Another good question I'm a little stumped by. I don't have an answer to that. It's traditionally been very difficult to track naloxone administration for a variety of reasons. So I don't believe there's very good data on how it's used by age. It is something, however, in our SUDORS database we could take a look at to see if younger versus older adults have more frequent administration. So great idea for future work.
Great. Okay, another question we have is, what are your thoughts on the risks and subsequent treatment for opioid overdose deaths and opioid use disorder for older adults, misuse of opioids for pain compared to recreational use? I have a lot of thoughts on that. I think it's an area we need to balance out in this work. I will say our interview project that I mentioned, one of the themes that has come up time and time again is that this idea of the pendulum swinging too far, that older adults with chronic pain had been treated with opioids, and now with rethinking opioid prescription practices, it's swung back and these people have been cut off, and then they're turning to illicits or non-regulated substances to treat that pain. We've heard that in our interviews, and I think that will be something to investigate going further. I do believe that will be a factor, and that's actually one reason why we want to look at the combination of physical health problems associated with opioid overdose death as well. Thank you. Here's a question. Are there specific opioid use disorder screening tools you recommend for the older adult, or what is your recommendation for screening? There are a lot of opioid use disorder screening tools out there. As far as I know, in my last reading, none of them had been validated for use in older adults. So I think it's kind of the wild, wild west out there in terms of what is the best screening tool for the older adult. One thing I would say about this is I think we have to reframe this screening in terms of, I noticed the person who asked the question said opioid use disorder screening. I think for the older adult, opioids are so dangerous, we need to just make that about opioid use screening. Because somebody could not have opioid use disorder and still be at very high risk for death by opioid overdose. Great, thanks. And I think I might add on there that the partners at Yale School of Medicine, their informatics center, and the GW partners both work with the VA, and the VA is testing out screening tools. So hopefully the VA will have something that can share more broadly. Okay, I have another question for you. Are there specific opioid use disorder? Oh, I already have that one. Sorry, next one.
Actually, Lori, there was a question that came into the chat that I'll just read here since I know you can't see it.
Sure.
So based on the increase in opioid use among seniors or older adults, how are senior living facilities in low income areas adjusting to how they service their clients? And is there an increase in education or preventive services at senior living facilities?
Really, really good question. I don't have the answer to that, but I will say, based on my reading of the literature, and of course I haven't read everything, that it is an issue of concern, but I haven't seen a lot of policy and program implementation around that. For example, one of the things we're working on with our naloxone distribution pilot is the idea of equipping building managers with naloxone and naloxone administration training. Could that be the case in assisted living or senior living centers as well? Things like that. So I think there's a lot of opportunities in terms of thinking through what the policy with a small p implications are for understanding this problem more clearly.
Great. Okay, another question. You gave a couple of demonstrations on cases of older adults that died from an opioid overdose death rate, and it seemed like they were dying from more than just opioids. So can you explain the difference between cause of death as an opioid versus multiple cause of death?
Really good question. So on average, the people in, not just older adults, but the people in our SUDOR's database have at least 6 to 7 substances on board. So there has been a move nationally to move from talking about opioid overdose deaths to talking about polysubstance overdose deaths in general. So I will say that. So cause of death, there is a cause of death where a particular substance can be named, or it can be polysubstance combinations, like some of the ones you've seen in the cases I shared. The deaths we've looked at have all included an opioid listed as a cause of death. So it may be in a polysubstance combination, or it may be an opioid standalone. But I think the point to understanding that is we're no longer in a opioid only crisis. We have many substances that are interacting negatively for people. In particular, cocaine, the combination of cocaine and opioids is increasing rapidly in our cases.
Right, and that leads to the follow-up question is, can you explain tweaking and how that's increased now with opioid overdose deaths?
Tweaking, as I understand it, is when people are basically creating combinations between an opioid and a stimulant to get a desired effect, and with the stimulants being a driver of behaviors. So people characterize tweaking, and I don't really like the term because obviously no one wants to be addicted and no one wants to have these issues. So tweaking makes it sound like it's more of a pleasurable activity, but I think it's really a way for people to sort of regulate their mood and their behavior. We do see more and more combinations of people who have stimulants and opioids as causes of death, though, and I think it will be continue to rise as we look at the data.
Great. I think that, does anybody else have a question? Okay, I want to thank you so much for attending today's seminar from IFAM. And I didn't know if you wanted to talk about next week's.
Oh, I can post the schedule in the
Thank you.
chat.
Great.
Yeah, it's going to be on constitutional eating, a traditional Chinese medicine approach to healthy eating for optimal health. So I will post that in the chat. But other than that, that is it.
Great, thank you. And I want to, thank everybody for coming, and I want to invite you to attend further seminars. It always leads to really interesting questions. And I want to thank our speaker today, Dr. Mason. Thank you so much. That was very informative. I appreciate that.
Yeah, and I'd like to just thank everyone for the opportunity, and please do reach out if you're interested in more info or collaborating.
Great, thank you so much. And with that, I will sign out from today. Thank you for your attendance, a great attendance. Anyways, so everybody have a wonderful day.